The topic is antibiotics for gram-positive infections. The learning objectives are first, to know the general spectrum of activity for antibiotics active against gram-positive organisms. Second, to be able to compare the spectrum of activity and major side effects of the antibiotics used for highly resistant gram-positive infections, that is, methicillin-resistant Staph aureus, or MRSA, and vancomycin-resistant enterococcus, or VRE. And third, to be able to select an appropriate antibiotic for infections with gram-positive organisms. As with some of the other lectures in this course, there will be several charts. Please do not try to memorize every detail of these. It's the general overview that is more important than each individual plus and minus sign. Also consistent with the common convention introduced in Lecture 1, when I discuss gram-positive infections, I am specifically referring to aerobic gram-positive organisms. Anaerobic infections and relevant antibiotics will be discussed in Lecture 6. So here's the first of these charts. This is an antibiotic susceptibility table for routine gram-positive infections, which are listed on the left. Methicillin-sensitive Staph aureus, coagulase-negative staph, group A and B streptococcus, strep pneumoniae, which you may recall is also known as pneumococcus, viridans group strep, Enterococcus faecalis and faecium, and lastly, Listeria. These are by no means the only gram-positive infections out there, but aside from MRSA and VRE, which I'll talk about in a minute, these are otherwise the most commonly encountered ones in routine clinical practice. The part 1 of this chart will focus on the penicillins and cephalosporins. So first up are the natural penicillins, most commonly penicillin G. The natural penicillins have no reliable staph coverage, but are great for most forms of strep. Although they usually have some activity against Enterococcus faecalis and Listeria, they are not the preferred agents for these infections. Instead, the aminopenicillins, consisting of amoxicillin and ampicillin, are the agents of choice for penicillin-sensitive Enterococcus faecalis and Listeria, and also provide coverage of group A and B strep and strep pneumoniae. When an aminopenicillin is combined with a beta-lactamase inhibitor to create either augmentin or unisin, good MSSA coverage is now added. The anti-staph penicillins, nafcillin, oxacillin, and dicloxacillin are next, and as you might have guessed, have excellent MSSA coverage and fair coag-negative staph coverage. Although there is some strep coverage, one would not use an anti-staph penicillin for an infection known to be caused by streptococcal species, as there are better beta-lactam options for that. The combination of an anti-pseudomonal penicillin and beta-lactamase inhibitor, as seen with Zosyn, provides broad gram-positive coverage of just about everything except viridin strep. Cephalosporins vary substantially in their gram-negative and anaerobic coverage, but for the most part, their gram-positive coverage is fairly similar, with only a few minor differences between individual drugs. Cephalosporins tend to have excellent MSSA and strep coverage, including viridin strep, but have less reliable coverage of coag-negative staph and have absolutely no coverage of Enterococcus or Listeria. Let's take a closer look at part 2 of this chart. The carbapenems, which are very broad-acting, cover all gram-positives well, with the exception of Enterococcus faecium. Also, as you can see, ertapenem, which is in this and some other ways ever so slightly less broad than the other members of this class, does not cover Enterococcus faecalis either. The quinolones, specifically levofloxacin and moxifloxacin, provide great Enterococcus faecalis, strep A, B, pneumoniae coverage, and fair staph and Listeria coverage. Ciprofloxacin is not listed because, as a general rule, it has inadequate gram-positive coverage to be considered a reasonable option for most gram-positive infections. Gram-positive coverage from the macrolides, most commonly azithromycin, but also clarithromycin, is fair with better coverage of strep pneumoniae and group A and B than anything else. Tetracyclines, which in the United States essentially means just doxycycline, has excellent strep pneumo coverage, but as with the macrolides, otherwise has less robust gram-positive coverage. Trimethoprim sulfamethoxazole, which goes by many other names, most common of which is Bactrim in the US and cotrimoxazole in many other parts of the world, has great gram-positive coverage with the exception of enterococcus and coag-negative staph. Finally, clindamycin covers MSSA a bit, as well as group A and B strep and strep pneumoniae. So that was a lot of information. Is there any way to distill this down into something more digestible and possibly even memorizable? Here's a list of preferred antibiotics for specific serious gram-positive infections. Keep in mind this list is very general. You always want to consider whether the chosen antibiotic will get to the organ in question, as well as consider your hospital and community's local resistance patterns. Instead of reading through the whole list, for those interested, I recommend pausing the video here and taking your time with it. That's because we can simplify things even further. Hopefully this next slide won't make any ID specialists shudder at its extreme overgeneralization. Staph infections, excluding MRSA, can typically be treated with the anti-staph penicillin nafcillin. Strep infections can typically be treated with penicillin G or ceftriaxone. Enterococcus and listeria can typically be treated with ampicillin, remembering that Enterococcus faecium is often resistant to common antibiotics. And vancomycin is the best alternative for all of the above in patients with serious penicillin allergies. For the remainder of the lecture, I'm going to focus on the highly resistant gram-positive bacteria, which essentially means just two organisms, MRSA and VRE. These are both resistant to typical conventional antibiotics and therefore represent a significant problem when patients are infected with them. Risk factors for developing these largely overlap. As you might expect, the most significant is recent antibiotic use, with cephalosporins and quinolones conferring the greatest risk for MRSA, and cephalosporins and vancomycin conferring the greatest risk for VRE. Other common risk factors are recent hospitalization, residence in a long-term care facility, and hemodialysis. Additional risk factors for MRSA only are injection drug use, HIV infection, and incarceration. So what antibiotics can be used for these highly resistant gram-positive infections? There are 6. Vancomycin, daptomycin, linezolid, ceftaroline, the combination of quinupristin and dalfopristin, better known by its trade name Sinercid, and tigecycline. Since these antibiotics are slightly less familiar to you than penicillin, cephalosporins, and quinolones, let me review them in slightly more detail. In addition to mentioning their mechanism of action and their coverage, I'll also list their notable adverse reactions. These are not necessarily the most common adverse reactions per se, but are reactions that either have high associated morbidity or are somehow unique to a particular drug. Vancomycin, as you may recall from the last lecture, inhibits cell wall synthesis. It has excellent coverage of MRSA, but by definition, no coverage of VRE. Its notable adverse reactions include red man syndrome, sometimes known as red neck syndrome, which is a rash or flushing of the face, neck, and upper torso. It appears during infusion or within minutes of completion, is due to nonspecific mast cell degranulation and not a true allergy, and can be avoided by slowing the infusion rate down. Vancomycin can also cause nephrotoxicity, ototoxicity, and neutropenia. Among the 6 drugs listed here, all of which are active against MRSA, the medical world has by far the greatest cumulative experience with vancomycin, and therefore it's considered to be the drug of choice when it's an option for MRSA. Aside from the side effects, other disadvantages to its use include poor penetration into the CSF, and drug levels often need to be monitored. Daptomycin damages the cell membrane, leading to fatal depolarization. It is active against MRSA and both VRE faecalis and faecium, though the latter a little less so. Its notable adverse reactions are myopathy, which requires weekly monitoring of CK levels, peripheral neuropathy, and very rarely an eosinophilic pneumonia. Linezolid prevents protein synthesis by inhibiting the 50S ribosomal subunit. It has great activity against MRSA and fair activity against VRE. It has a number of relatively distinct side effects as far as antibiotics go, including myelosuppression, lactic acidosis, neuropathy, optic neuritis, and can trigger serotonin syndrome when combined with a number of other drugs. A major advantage of linezolid over the other 5 drugs listed is that it is the only one available PO. Ceftaroline is a so-called 5th generation cephalosporin, which as a beta-lactam inhibits cell wall synthesis also. It is the only beta-lactam which covers MRSA, but has no VRE coverage. It is the newest of the 6 to be approved in the US, and there really isn't a whole lot more to say about it. The drug more commonly known as Sinusid is actually a 30 to 70 combination of quinupristin and dalfopristin, which are compounds in a class called streptogramins, which inhibit the 50S subunit. Although Sinusid has some MRSA coverage, its real use is as one of the best antibiotics we have against VRE faecium. Interestingly, there is no coverage of VRE faecalis. As many as 50% of patients on Sinusid will get myalgias and arthralgias. And because of a very high risk of thrombophlebitis, Sinusid can only be given via a central line. Finally, tigecycline inhibits the 30S ribosomal subunit. It's active against all 3 bacteria. It can increase LFTs, causes photosensitivity, and may very rarely cause pancreatitis. In 2010, the US Food and Drug Administration released a statement that tigecycline was associated with a very small but statistically significant increased risk of death compared to other similar antibiotics. This increased risk may be limited to those indications that are not FDA approved, such as ventilator-associated pneumonia, though the actual explanation of the increase is not definitively known. Hello again, this is the 5th lecture in this course on antibiotics, and today's topic is antibiotics for gram-negative infections. The learning objectives are first, to know the general spectrum of activity for antibiotics against gram-negative organisms. Second, to be able to compare the spectrum of activity and major side effects of the antibiotics used for highly resistant gram-negative infections, such as those by Pseudomonas, ESBL, Acinetobacter, and Stenotrophomonas. And last, to be able to select an appropriate antibiotic for infections with gram-negative organisms. As with the last lecture, I'll start with a general antibiotic susceptibility table. Less available information in references and the literature means that the assignment of pluses and minuses with this lecture will necessarily be more arbitrary than the last, but I'll do my best to have these signs represent a combination of typical in vitro activity and clinical usage. And I'll just cover the most clinically relevant gram-negatives. The majority of these are enteric gram-negative rods. Although there is much overlap with the clinical diseases they cause, these enteric gram-negatives tend to form groups with similar antibiotic resistance patterns. For example, E. coli, Klebsiella, and Proteus typically share a similar resistance profile, as do Enterobacter, Serratia, and Citrobacter. Another important gram-negative bacteria is H. flu, as is the genus Neisseria, to which belongs the species Neisseria gonorrhoeae and Neisseria meningitidis. As the first generation cephalosporins have poor gram-negative coverage, I'll start just with the second generation, which cover the E. coli Klebsiella proteus group very well, along with H. flu. The third generation cephalosporins add good Neisseria coverage and some activity against the Enterobacter Serratia Citrobacter group. And the fourth generation cephalosporins, predominantly cefepime, shows excellent activity against all of these. Combinations of aminopenicillins and beta-lactamase inhibitors, as in Augmentin and Unison, have excellent coverage of everything listed but the Enterobacter Serratia Citrobacter group. And the anti-pseudomonal penicillin beta-lactamase inhibitor combo, Zosyn, has great coverage of routine gram-negatives that is equal or near equal to cefepime. Looking at a couple more of the antibiotic classes, carbapenems have great coverage of everything as well. Here is aztreonam. And quinolones are interesting in that they have excellent activity against most things, with the exception of rising resistance specifically in E. coli, that has been seen in the last 5 years or so in the United States. Also, resistance to quinolones among Neisseria is highly specific to geography, with some countries measuring a 10% resistance rate and others a 100% resistance rate. Aminoglycosides cover all of these well except Neisseria. Most of the species listed so far don't usually pose a significant treatment challenge, provided adequate source control and host immune function. However, there are a collection of gram-negatives that are classified as highly resistant. That term is variably defined, more so with the gram-negatives than with the gram-positives, as we saw in the last lecture. Based on how they impact the clinical care of a patient, I personally consider the highly resistant gram-negatives to be, first, Pseudomonas, second, ESBL. ESBL is an interesting term that many doctors use grammatically as if it were a specific bacterial species in itself. But ESBL actually stands for extended spectrum beta-lactamase, and the term is usually used interchangeably with ESBL producing bacteria. ESBL producing bacteria are always aerobic gram-negatives, most commonly strains of E. coli and Klebsiella. What exactly is ESBL? Well, typical beta-lactamases are bacterial enzymes that confer resistance to penicillins and narrow-spectrum cephalosporins by cleaving the beta-lactam ring of those drugs. ESBLs increase resistance to also include the anti-pseudomonal penicillins like Zosyn, the third and fourth generation cephalosporins, and Aztreonam. The result of this is that it greatly limits the number of antibiotics that are available to fight these infections. Also on the list of highly resistant gram-negatives are Acinetobacter and the tongue twister Stenotrophomonas, both of which are usually just seen in either ventilator-associated or hospital-acquired pneumonia. All four of these share some common risk factors: prolonged or recent hospitalization, recent antibiotic use, mechanical ventilation, residence in a long-term care facility, and indwelling catheters, lines, and tubes. In addition, each bacteria type has been found to have some additional specific risk factors as well. Species-specific risk factors for Pseudomonas include immunodeficiency, cystic fibrosis, bronchiectasis, and severe cutaneous burns. Risk factors for ESBL are emergency abdominal surgery. Acinetobacter shows significant seasonal and geographic variation, being most common in summer and in warm and humid climates. Exposure to war or natural disasters has also been found to be a risk factor. And risk factors for Stenotrophomonas include immunodeficiency and cystic fibrosis. Antibiotics to consider when treating one of these highly resistant gram-negative infections include the third-generation cephalosporin ceftazidime, cefepime, piperacillin and tazobactam, carbapenems excluding ertapenem, aztreonam, aminoglycosides, and colistin. Let's take a look at these in some more detail. Ceftazidime inhibits cell wall synthesis. It is great against Pseudomonas with some activity against Acinetobacter and unreliable activity against Stenotrophomonas. Notable adverse reactions include the possibility that it lowers seizure threshold. It's the only third-generation cephalosporin with anti-pseudomonal activity. Cefepime, a fourth-generation cephalosporin, also inhibits cell wall synthesis. It's active against Pseudomonas and a little against Acinetobacter. Cefepime also lowers seizure threshold and, interestingly, can cause a positive Coombs test without triggering hemolysis. Piptazo or Zosyn has excellent Pseudomonas coverage, has so-so Acinetobacter and Stenotrophomonas coverage, and occasionally but not usually covers ESBL. Remember that the anti-pseudomonal dosing of Zosyn is higher than regular dosing. The carbapenems, specifically imipenem and meropenem, have excellent Pseudomonas and ESBL coverage and some Acinetobacter. The activity of ertapenem against Pseudomonas and ESBL is less robust and should be avoided when these pathogens are suspected. Aztreonam only really covers Pseudomonas among these four, although it's usually reserved for patients with a severe beta-lactam allergy, as there is generally no cross-reactivity. It should not be used in patients who have had a severe allergic reaction to ceftazidime, as the two share a side chain and thus a theoretical risk of cross-reactivity. Aztreonam has no activity against gram-positives or anaerobes. The aminoglycosides, which inhibit the 30S ribosomal subunit, have great activity against Pseudomonas, with some activity against ESBL. The aminoglycosides have significant adverse effects, most prominently nephro and ototoxicity, which necessitates close monitoring of serum drug levels. The aminoglycosides also have poor lung penetration, though tobramycin specifically is available in an aerosolized form that is useful in treating pseudomonal infections in patients with cystic fibrosis. Colistin, also known as polymyxin E, is an interesting antibiotic. It works by damaging the cell membrane and shows at least some activity against all four of these difficult to treat pathogens. Despite most clinicians assuming it's a new antibiotic developed to treat highly resistant strains of Pseudomonas, it actually was discovered in 1947 and used significantly in the 1960s and 70s, at which point safety concerns led physicians to abandon its use in favor of newer options. However, the evolution of antibiotic resistance has demanded a return of attention to it. And in retrospect, concerns over colistin's toxicity may no longer be quite as great. We understand more about its pharmacokinetics, understand appropriate dosing, are using different and more purified forms of the drug, and can monitor more closely for side effects. Today, toxicity of colistin may actually be less than that of aminoglycosides, the use of which initially supplanted colistin because they were felt to be safer. For now, however, colistin remains the agent of last choice for the most highly resistant gram-negative infections. There are a few more gram-negative antibiotic pearls of which you should be familiar. As you may recall from Lecture 3 on the classification of antibiotics, ciprofloxacin and levofloxacin show generally good activity against Pseudomonas. Also, the combination of ampicillin and sulbactam, which is marketed under the name Unicin in the US, usually has good activity against Acinetobacter and may be a reasonable, more narrow-spectrum alternative to the above. Finally, trimethoprim sulfamethoxazole has excellent coverage of Stenotrophomonas and is generally the antibiotic of choice when no contraindications exist, such as renal failure. I'm going to end this lecture with a discussion of a common question that arises during treatment of a possible pseudomonal infection. Should an empiric antibiotic regimen chosen for possible pseudomonal infection contain not one, but two antibiotics active against this bacteria? While I can't speak about the rest of the world, this is fairly common practice in the United States, most prominent when treating a suspected pseudomonal pneumonia. The exact combination used is usually an anti-pseudomonal beta-lactam plus either an anti-pseudomonal quinolone or an aminoglycoside. The theoretical benefits of this approach include an increased chance that the suspected pathogen is covered by at least one antibiotic prior to the microlab's reporting of sensitivities, prevention of resistance emerging during therapy, and exploitation of synergy that may be observed in vitro when two agents are used simultaneously. Despite these theoretical benefits, the clinical data supporting this approach is relatively weak and conflicting. A 2003 Cochrane review concluded that there were worse outcomes when an aminoglycoside is added to a beta-lactam for empiric treatment in cancer patients with neutropenic fever. A 2006 Cochrane review concluded there was no benefit to adding an aminoglycoside to a beta-lactam for empiric treatment in sepsis, but did find increased nephrotoxicity with double coverage. And a 2008 meta-analysis of 41 randomized controlled trials evaluating empiric antibiotic regimens for suspected ventilator-associated pneumonia found that overall monotherapy is not inferior to combination therapy in the empiric treatment of these infections. However, the methodologic quality of the trials included were noted by the authors to be low, and other experts in the field have criticized the meta-analysis itself for reaching an overly broad conclusion when the included trials generally did not specifically include the patients who are at highest risk of having multi-drug resistant organisms. This is lecture 8 in this course on antibiotics. The topic is important side effects and toxicities. The learning objectives are first to know the common side effects and toxicities of antibiotics, including allergic reactions, diarrhea, C. diff colitis, QT prolongation, and interactions with warfarin. Here are some important points about patient reporting of a prior drug allergy. First, reporting of an antibiotic allergy is not reliable. For many patients, the supposed reactions occurred in childhood, and they no longer even recall the actual reaction themselves. In fact, multiple studies consistently have found that only 10 to 15% of patients who self-report a history of penicillin allergy are actually shown to be allergic after undergoing skin testing. One reason for this is that patients may incorrectly report adverse reactions, such as nausea, diarrhea, and headache, as allergies. And some patients eventually lose their anti-medication IgE after enough time has elapsed since their last systemic reaction, which may require 10 years or more. Patients with specific reaction histories are much more likely to be truly allergic than those with vague histories. For example, if a patient were to tell me that she can't take penicillin because she had, quote, anaphylaxis, requiring a week-long hospitalization after a dose of amoxicillin, I would believe that much more so than if a patient reported that she can't take penicillin because her parents always told her something bad had happened after she was given it as a baby. I'll next talk for a few minutes about penicillin and cephalosporin cross-reactivity, as this issue comes up all the time both on the wards and in clinic. One common scenario is a patient who is admitted with community-acquired pneumonia and reports a history of a penicillin allergy, leading the treating team and/or pharmacist to be apprehensive about giving ceftriaxone. There is a widely cited fact that 10% of patients with an allergic reaction to penicillin will have a cross-reaction to a cephalosporin. This is completely false. This dramatic overestimate is based on studies from the 1960s and 70s, which had significant methodological flaws, among which were an inappropriately loose definition of allergy. These studies were done during a time when drug manufacturing techniques led to greater risk than today of contamination of one drug with another. Also, they failed to account for the observation that patients with significant allergies to penicillins actually have an increased risk of allergy to any medication, irrespective of structural similarities. In reality, the risk of cross-reaction between penicillins and cephalosporins has been reported to be as low as 0.5 to 2.5% for first-generation cephalosporins, and near zero for most second, third, and fourth-generation cephalosporins. The likely reason for this difference between generations is that first-generation cephalosporins generally have side chains which are structurally more similar to penicillins than do the other generations. Let's look at those side chains in more detail. Here are the general structures of the penicillins and cephalosporins. We can see that 4-member beta-lactam ring in the middle of both. In addition, penicillins have one variable side chain, denoted here by the letter R, and cephalosporins have 2. It is these side chains which are responsible for the differences in activity and effect between members within the same class. Although there is some debate about this, the beta-lactam ring itself is thought to be generally an uncommon trigger for an immunogenic response, and true allergies are usually triggered by an R side chain. To understand what this means, let's compare the penicillin amoxicillin and the first-generation cephalosporin cephalexin. Notice how similar these two side chains are. While not quite identical, the degree of similarity suggests the possibility of a cross-reaction between these two drugs. In contrast, here is the structure of the third-generation cephalosporin ceftazidime. That side chain is dramatically different, leading to a near-zero risk of cross-reaction. In summary, patients who report a penicillin allergy can be safely given a cephalosporin if all of the following are met. The allergy history is not suggestive of a type 1 or IgE-mediated reaction. The reaction occurred more than 10 years ago. and the cephalosporin has a dissimilar side chain from the penicillin. Otherwise, the clinician must weigh risks and benefits of administration of a cephalosporin. One more thing before moving on, one should always consider medical legal liability based on your medical community's common practice and standards of care prior to prescribing cephalosporins in patients with a reported history of penicillin allergy. The aforementioned 10% cross-reactivity rate is still widely cited and believed, even if it's not true. When it comes to being sued or reprimanded by your institution, common perception usually carries greater weight than scientific truth. Yet another common toxicity involves interactions between antibiotics and warfarin, also known as Coumadin. Warfarin is a common oral anticoagulant used in the treatment of patients with venous thromboembolism, atrial fibrillation, and mechanical heart valves. It has a narrow therapeutic range and requires frequent monitoring of the INR to prevent excessive risk of bleeding. Concurrent use of antibiotics is associated with an increased risk of over-anticoagulation. The major mechanism for this is via a disruption of normal intestinal flora that synthesize vitamin K, which is a cofactor for the body's endogenous clotting factors, and thus it antagonizes the actions of warfarin. As with C. diff colitis and QT prolongation, the risk of a clinically significant interaction with warfarin is not the same for all antibiotics. Here are the results of a case control study of 39,000 patients aged 65 and over on warfarin, and the odds ratio for needing hospitalization due to excessive bleeding, broken down by class of antibiotic administered. For those of you not familiar with odds ratios, an odds ratio of 1 means there is no increased risk. Odds ratio greater than 1 means there is an increased risk. And so all antibiotics here were actually associated with increased risk, and all of these were statistically significant. The fact that the greatest effect was seen with the azole antifungals and trimethoprim sulfamethoxazole is due to their inhibition of CYP2C9, one of the main enzymes responsible for metabolizing warfarin. The consequence of the findings of this study is that a patient's INR, which is a surrogate for the anticoagulation effect of warfarin, should be monitored at least weekly for patients on concurrent antibiotics, and probably more frequently for patients with additional risk factors for bleeding. Occasionally, for patients on warfarin for atrial fibrillation or other low-risk indications, the warfarin dose may even be proactively lowered when antibiotics are started. I'm going to quickly run through a list of ones which the average internist should know. Some of these will hopefully sound familiar from prior lectures. Ceftriaxone can lead to something called biliary sludge, which occurs when solutes in bile precipitate in the gallbladder. Although it's not a solid gallstone in the traditional sense, it predisposes the patient to all of the same complications as gallstones, including biliary colic, acute cholecystitis, and pancreatitis. Vancomycin causes a self-limited cutaneous flushing of the neck and upper torso, known as red man syndrome or occasionally as red neck syndrome. It also causes ototoxicity and, although not listed, on rare occasions, nephrotoxicity. Daptomycin can cause a myopathy requiring weekly checks of creatine kinase. It has also been very rarely associated with an eosinophilic pneumonia. Tigecycline can lead to transaminitis and photosensitivity. Linezolid, which most people love as it is the only oral medication that very reliably covers hospital-acquired MRSA, unfortunately has many side effects. They include reversible myeloid suppression, lactic acidosis, peripheral neuropathy, optic neuritis, and serotonin syndrome when combined with other serotonergic drugs. Aside from serotonin syndrome, the other toxicities of linezolid generally occur only after 2 weeks of treatment, which is why some clinicians limit linezolid courses to that duration. Quinupristin dalfopristin, commonly known as Sinercid, leads to myalgias and arthralgias in nearly half of patients. Like linezolid, the quinolones have a number of seemingly random toxicities. In addition to QT prolongation, they can cause either hypo or hyperglycemia, tendinopathy, and a false positive urine tox screen for opiates. They can also exacerbate myasthenia gravis and are considered contraindicated in patients with that condition. Trimethoprim sulfamethoxazole can lead to hyperkalemia, which I've found to be a relatively common side effect. Nitrofurantoin has a rare idiosyncratic toxicity of pulmonary fibrosis, which can be fatal, along with hepatitis. Colistin has significant rates of nephrotoxicity and neurotoxicity. Carbapenems may lower seizure threshold. Metronidazole has a disulfiram effect in which the drug interferes with the metabolism of ethanol, leading to a buildup of intermediate metabolites that can make people feel awful after consuming alcohol. Doxycycline leads to erosive esophagitis, necessitating its administration with plenty of fluid and not at bedtime. It can also cause photosensitivity. Finally, the aminoglycosides, in addition to substantial nephrotoxicity, can also exacerbate myasthenia gravis, and like the quinolones, are contraindicated in those patients.